we were talking about when you find like cannonball metastasis and rib destruction, which is a lytic pattern. So you will think about metastasis. So where the primary, where it will be the primary, where do you expect the primary? And yeah, renal cell carcinoma. Huda, welcome Huda, thank you. So yeah, it will be in the retroperitoneum. So go and look for any clue for renal cell carcinoma, which give you metastasis for yeah. So anything like thyroid, renal, CT, MRI. You remember CT, MRI, choriocarcinoma, C, melanoma. A clue, but renal cell carcinoma, one of the famous who make this cannonball metastasis. So this scenario, you should be in the exams, and also maybe in the practice one day, you can see something like this. Okay. Yes. I think this one we discussed it many times, but let's try to describe. So you'll start the radiograph, which is here the AB or frontal and lateral radiograph of immature skeletal patient or pediatric age group patient. So you have what is called vertebra plana in the age group. So one of the most important to put eosinophilic granuloma or Langerhans cell histocytosis. Okay. And maybe they will ask you about the other skeletal manifestation of the Langerhans or eosinophilic granuloma, which it can be in the skull, like calvarial lytic lesion with baton sequestrum and beveled edge. Maybe diametaphyseal involvement of long bones with infiltration. Maybe some lytic lesions with or without preosteal reactions. Yes. And some of them can resolve without treatment, have something called spontaneous regression. Yeah. So maybe we'll ask you about the differential diagnosis of vertebra plana. So eosinophilic granuloma, lymphoma and leukemia, trauma and TB. And finally, if it's old patient, you can think about myeloma and metastasis. Okay. So the skull lesion, that I want to show you this, what is called lytic lesion in the skull with beveled edge and baton sequestrum. Okay. So this patient who have frontal radiograph, what can you see in this patient? So try to describe. So in the frontal radiograph, you have your checklist. So you can, yeah, there is calcified what? You can see that there is multiple calcifications. Yeah. And if you go to check the spaces, the disc spaces, maybe there is narrowing here. So psoas region, it looked like there is psoas lesions, bilateral and calcified. So paraspinal calcification, Huda, perfect. Nice. Paraspinal calcifications, and there is also some calcification projecting over the kidney. Yeah. What else? I see the answers. Aina. Thank you. Yes. Okay. Let me show you the lateral after you see the AB or the frontal. Now I show you the lateral. So this is the calcifications here. Look what happened here in this vertebra. So if you consider this L5, so you can see what happened to L4 and the disc space between L3 and L4, right? Almost the disc space is very narrowed or lost, and there is distraction, right? And there is sclerosis of the end plates. And you can say that there is ankylosing. So describe it well. Yeah, ankylosing. And with the calcified psoas abscesses or the calcified paraspinal psoas lesions, maybe you can think about what is called TB. Yes, TB, tuberculosis. Nice. So this is what's called Bott's disease or TB. So calcifications, this is the titles. After you finish your checklist, you will find that the titles will be paraspinal calcifications, and some of them like psoas collection or abscesses calcified, plus the joint space affection and the destruction of this vertebra. Okay, so most probably it will be TB spondylitis or Bott's disease. So the TB, it come like hematogenous spread from the TB bacilli. In the long bones, they like, especially in childhood, they like the epiphyseal position. In a child, it like the metaphyseal affection and the cross to the epiphysis. Okay. Just I want to show you something. So when you mention that calcified psoas appearance, the calcified psoas in the MCQ or in the exam, so for you, like most commonly, it will be TB. Okay, when you find calcification or calcified collections along the psoas, it will be pathognomonic for TB, most probably. Also, the destruction and the affection of the joint space, more going to be with TB. Yeah. So this is typical for TB spondylitis. They like sure that they like to ask you about the difference between the pyogenic and the TB spondylitis. How you can differentiate between both. So how you can differentiate between TB spondylitis and pyogenic spondylitis. So TB like to be multiple levels of involvement. Yeah, multiple level TB, multi-level, perfect. This is what is called subligamentous spread. So it like to spread along subligamentous aspects. So TB is multi-level. The usual position of TB thoracic, here it is lumbar, but yeah, it is usually in the dorsal spine or thoracic spine. The destruction, they like to mention that it's indolent, yes. And you can see easily the calcified paravertebral paraspinal masses. Sometimes the absence of sclerosis. Yeah. And the T2, they mentioned that it have hyperintense signal in T2. Yeah. Okay. I think this one is easy one, but let's describe it. So this is like a frontal and oblique radiograph of the foot. Try to mention, is it like a joint pathology, or like it is more in the, how you describe it? So maybe you can start with this fracture in the second and first metatarsal. Yeah. And you can see that there is maybe like trial to make callus formation or exuberant callus here and here. Yes, and there is widening, distension of the joint space, widening, and there is destruction of the articular surface. Perfect. Also, maybe you can see that there is some affection in this joint, metatarsophalangeal joint as well. Okay. So what is your impression after that? What is your impression? Again, destruction. So the big titles, after you finish your description, you'll find that there is destruction, which is multiple D's. You remember the D's: destruction and some osteopenia, the demineralization. Yes. So the first title be for you in differential diagnosis, which should be neuropathic joint. Yeah, neuropathic joint or Charcot joint. Maybe due to diabetes, maybe. So you'll ask in the history about diabetes. Perfect. Maybe the question they will ask you that what the causes of neuropathic joint other than diabetes. So you can mention some causes like alcoholism, syringomyelia, maybe syphilis, myelomeningocele, and so on. So how you can know that maybe this patient going to have infection, or at least he have infection? So you will search for gas lucency. Yeah. So if you find gas lucency or ulceration, skin ulceration in the, so this patient mean that he developed like infection, or maybe some sclerotic sequestra or periostea reaction, as in this case. So the most common cause for Charcot joint, which is like the uncontrolled diabetes. This is the most common cause, long-standing uncontrolled diabetes. The usual affection is the ankle and the foot. So as in this case, you will mention that joint changes, but probably joint changes with no trauma. So you will ask if this any trauma in this patient happened. If there is no trauma, then the Charcot will be the most probable. Search for any vascular calcification in the image. It will help you to determine that it is diabetic. Okay. So they mentioned that the typical diabetic fractures, it will be, as in this case, it will be subchondral fracture of the metatarsal head. So this is the usual location of diabetic fractures. They call it sometimes diabetic fractures. Subchondral fracture of metatarsal head, especially the second one. Okay. And maybe the posterior calcaneus tubercle with a Vulgent fracture. Sometimes they have something called talocalcaneal fragmentation. I will show you now. So sometimes it have what is called telocalcaneal fragmentation between the talus and the calcaneus. There is much fragmentation happen. So all this give you the impression of the Charcot. You know that, is it like the midfoot? Yeah, this is the midfoot. So neuropathy start with the subluxation in the midfoot. Yeah. Okay. And you can find something here in this image. What is the most striking finding here, plus the Charcot joint? Yes, Zoom user, thank you. Less frank. So you can see the less frank dislocation here. So less frank fracture and dislocation. And we mentioned that in less frank you have two types of less frank, either divergent or convergent. So this one, which type? And always when you find the Charcot joint, yes, Aina, thank you. So when you find the Charcot joint, you will think about less frank. And when you find less frank, ask about trauma. If you don't find the trauma, then go search for Charcot. Okay, so they are together. If you find the Charcot joint, go search for less frank. And if you find less frank, go and ask first for trauma. If there is no trauma, then go to suspect that it is neuropathic joint, then go and see the ankle. Okay. So also neuropathy, when you find neuropathy, search for infection. That's why you will ask for MRI in the next step, and MRI with contrast to see if this could be with infection or not. Okay. Again, the causes of Charcot neuropathic joint will be myelomeningocele, alcoholism, and it can make like peripheral neuropathy. Something called congenital insensitivity to pain, and something called Charcot-Marie-Tooth disease, and leprosy and syphilis. Anyway, at least you should know that the diabetes will be the most common cause of this. Okay. Now we go to the second step in this session tonight with the rapid reporting, and this is more for the FRCR side. But again, in the ADIR, they like to show you something in the short cases that maybe it's anti-many. So be careful about the subtle fractures. In the FRCR, okay, I will mute the audience. And the FRCR is like they give you 30 cases of rapid reporting, and almost like 50% of these cases are normal. Then it is your role to know which is abnormal and characterize it well. So for example, here, the abnormality is in the little finger. So probably you should make some zooming to find the little finger abnormality, and focusing by your eyes, like what I do now, in the little finger to know what is the abnormality. So maybe if you are lucky, you can see the fragment which is affecting which is very subtle fracture. Yeah. But with some zooming, you can know that the fracture is in the little finger. Yeah. It will take from you a while until you are used, but let's train here. So again, in the fifth finger, as in this case? Can you, yeah, it's the same case, sorry. Yeah. So what is the abnormality here? This one is easy one. There is a problem with the, okay, the voice is fine or still? I think I already mute everyone. There is someone is not muted. Okay. Okay, so what is going here? So it is, yeah, acromioclavicular joint subluxation. Ala, thank you. No, sorry. You can see that the abnormality here in the wrist. So how you can find it? What you find abnormal here? Yes, it is the leonate. Thank you, Aina. Leonate dislocation. I agree with you. Let's imagine like this, okay? And if we go to this case, which is a bit difficult case, then I will make for you some zooming to imagine what is going here. So this could be apophysis, but this apophysis have what? So the apophysis should be oblique. So when you find like transverse line, so it is apophyseal fracture. Yes, perfect. Okay, nice. And yeah, thank you, Zoom. And here you will search for something acute, so they don't care for any degenerative changes. So the acute will be in the middle finger, and he show you this middle finger. Yes, so the fracture is here with a avulsion fracture. Okay, avulsion fracture. Okay, perfect. So again, in the middle finger here, and maybe you need again some zooming. I think now it is a bit easier one. Do you see the avulsion fracture? If you see it, it is in the middle or the distal. Yeah, it is here. Perfect. So you need just make some zooming and changing some window, editing the window until you find it. Okay. Maybe I will help you to show you this one. So in the elbow, you can see that the dysborosis, which is the olecranon process, it have something defective, and you can see some fragmentation. So this is what is called a avulsion fracture with off olecranon. Perfect. Process. Perfect. And if we go to the maybe one of the base of this phalanx, I will show you now. It's not very clear. I'm trying to show to you, but Not very clear. Okay, let's skip it. Maybe this one more clear. Yeah, this one is more clear. Very subtle fracture, but it present, okay, in the base of the middle phalanx. Okay, I will just skip some of this and show you something which is, yeah, this one was tracheal. I agree with you. This one was tracheal fracture. Perfect. Nermeen. This one is very important to know. So do you think that this is the fracture here? No or yes? No? Perfect. So it's not this one. This is the sesamoid bone. So where is the fracture here? It will be in the base of the fifth metacarpal here. Perfect. Huda, thank you. Of the first, sorry. I mentioned fifth. No, first metacarpal here. Always you saw it before, so now I think it will be easy for you to see the buckling. So in pediatric age group, the fracture comes sometimes in the buckling, so metaphyseal buckling. Perfect. Okay. Sometimes they like to show you other than fractures. Other than fracture, that you want to show you this this type of so no, Huda, no. No, it is not. This is can you see the scapula here? Try to focus in the scapula. Yeah, thank you, Aina. Aina, welcome with us. First, Huda and Aina, thank you for joining us. I see that you are very active. Yes, so the lesion is exactly here. Perfect. So try to trace the scapular border here. You will find that there is soft tissue lesion, and you can find that this is, yeah. So destructive lytic lesion probably, or destructive lesion at least, with soft tissue component. Then finally, you will mention this, okay? This is the component of the rapid reporting, yeah. Thank you for this red line. Can you delete it, please? Okay, and this is important in the exam, what is called the zigzag line. So this zigzag line, you should trace it, and it shouldn't be like this. So this exact line, it should be clear that you should be for you like a zigzag. So when it's lost like here, you cannot find this exact line. So this is what is called metacarpal dislocation. Yes. So dislocation can happen in the metacarpal. So the clue for you is to draw this exact line. In the checklist, when you go to check the metacarpal joints, and when you find this exact line is disrupted, so sometimes it's just disrupted in the fifth or the fourth, but here is disrupted from maybe the third until the end, until the fifth. This is what is called metacarpal dislocation. Okay, sometimes it's very subtle, but you should be aware of it. Okay, and the clue that you can find that this basis of metacarpals go back in the true frontal radiograph and go back and behind the hamate. Yeah, behind the hamate. So you should be aware of this. Let's go to this again. So now the zigzag line again is disrupted, and you can see that the third and the fourth and fifth all go below the zigzag line. So this line, so it is disrupted again. So this is dislocation. I won't show you maybe. Yeah. This one we already mentioned before. It is dislocation of leonate. We have about 7 minutes. I want to show you one case because we want to know who will be the radiology star tonight, our star. So let's show you this case. So sorry. Okay, so just show you, and when you pick up the abnormality, just write a comment, and I will give you the 10 flowers today. So what it would be, just I will make the field more wider to help you. Maybe I will change the window, long window, to see if there is any abnormality. And you can see that there is one nodule here and one pulmonary, maybe subpleural nodule here, and another one, but it's calcified. Do you see them well? And here, okay, so there is some pulmonary nodules. Do you agree with this? Okay, now I will show you the neck. This patient, they find something and they want to know, is it something suspicious or not? So what do you think? What is this something, and what do you think about it after it is suspicious or not? So who will be our star tonight? And he will take the 100, maybe 100 flowers. Yeah. Okay, maybe there is some, I agree with you that the thyroid is asymmetrical, maybe some mild enlargement, maybe. Huda? You mentioned that there is some lymph nodes here, right? Yeah, I agree with you that there is prominent lymph nodes here and here. Maybe yes, I agree, but you will measure them and see if they exceed the pathological size. You will mention them. Okay, I agree with you. But what is the striking finding? Still, there is a striking finding that it needs from you to focus and detect it. And 100 flowers is nice. So go and check for laryngocele. I don't know. I think it's not laryngocele. No, there is no laryngocele. Roa. Okay. Maybe we check. No, the esophagus is fine. This collapsed esophagus. Some atherosclerotic changes in the aortic side. I agree with you. Okay, I am waiting for someone who can pick the big abnormality for tonight and become the star for tonight. Okay. No, I don't mention diagnosis. I just want you to describe the abnormality. Where is it? Where is it? Where is it, and what is it? Maybe what is it is okay. Yeah, soft tissue lesion, but wait, where? Where is it? Nirmin, thank you, but where is it? Okay, perfect. Our biggest star Nirmin today, yeah. 100 flowers, yeah. Right, supraclav, perfect. Look in this, in the fat plane here. Yes, this one. Sometimes when you go in this region, you skip it, or at least you don't focus, because this is the region where the axillary and subclavian, either vein or artery, go. But there is a soft tissue here, you see? And this soft tissue is running beside the vessels and the neurovascular bundle. Yeah. And if you go to the other side, you will not find this. You will find just a fat in the supraclav region. So the patient come because he have suspected swelling, which is suspected in the supraclav region, and they want to know it is suspicious or not. So what do you think about it? Is it suspicious? This patient age about 70 years old. So do you think that it is suspicious soft tissue? Yes, can be lymphadenopathy, can be nerve sheath tumor because it is in the neurovascular bundle, or neurogenic tumor. And you can see that there is some extension through the foramina, yes. So they go with the entrance of the transverse foramen. It can be soft tissue tumors like liposarcoma, maybe, why not? So anyway, you will put like suspicious lesion, right, as a first possibility, and maybe you will need to take biopsy. You agree? So your next step may be that you will suggest to take biopsy on this lesion to know exactly what it could be, especially in this age. And don't forget that this patient have some pulmonary nodules, which can be non-specific or indeterminate, but could be also as metastases, right? So maybe it could be a metastasis, okay? So do you agree with me that now it's going more with the suspicious criteria? And it's important to see that this is the space, is very dangerous space, supraclavicular region, that you should be careful, okay? Thank you, Nirmin, our big stars today. Let's go to the final. We have about maybe 10 minutes, so if it is disconnected, we have still the PET-CT cases. So if you like, we can show you some PET-CT cases as we are used. Pick up the abnormality quickly. Yeah, the sternal, nice, Huda, Aina. So the sternal pathology here, okay, nice. Do you see any abnormality here? So yeah, I will show you. Yeah, this is here. This is the soft tissue or lesion, bony lesion, sorry, with soft tissue extension. So do you see any abnormality here? Okay. Try to collect with me the finding. Maybe you can note that there is some spinal lesions here. This one is high in T2, maybe is not, but this one is low in T2. So it could be like a suspicious lesion. Okay. Now the time to do PET-CT. He did PET-CT for some reasons we'll know now. You'll know after a while, but you can see that there is lesion in the liver with the high FDG uptake, especially along the margin. And you can see that the center is photopenic. So can you imagine the cause for this, why it is not high in FDG uptake like the margin? Perfect, Aina. So this is a necrosis. So this means that this tumor is highly, it can be highly malignant. And this is the sternal pathology I showed to you from Wild in the MRI. Perfect. Okay. Yeah, you can see it clearly here with high FDG uptake. So it can be, this is sternal pathology, and the liver have this lesion. So what do you think? Again, you can look in the spine and you can see that there is vertebral metastasis. In the CT again, in the sternum, you can see the affection of the sternum. It can be like HCC with metastasis. Yes, it can be like HCC and metastasis. But they mentioned that this one, it is metastatic cancer colon to the liver. So even in the liver, it is metastasis and metastatic to the sternum. So they take the pathology and they find that this patient have cancer colon, already have history of cancer colon, and this is metastasis in the liver, okay? But it is good differential, yes, it's good differential if this patient don't have history, to mention that it can be HC, and we show before the HC, not very common to take uptake, but if take uptake, yeah, it can happen. In this case, you already can see that the lung and the liver have lesions with very high uptakes. This in the kidney maybe is just excretion, but in the liver you can see that this very high lesions, very high uptake in the liver. So either it is primary or secondary, but secondary is more common to be. So it can be metastasis. Yeah, multiple metastases, some of them in the lung. Okay. And this one, it was again cancer colon with liver metastasis. Okay. I won't show you this case. Maybe this one, it will be more easier one. So in the liver, you can see this lesion. In the lung, you can see this high uptake lesion, which is denoting that this patient have pulmonary nodule. And then you can see that there is peritoneal lesion with high uptake, like it is peritoneal metastasis as well. Okay. liver lesion. So cancer colon again, multiple liver metastases from cancer colon. So cancer colon can present with many, yeah. Let's go to this case. I show you the answer already, but look in the cardiac image and you can see soft tissue lesion. So the most common lesion in the cardiac, yeah, it is the most common malignant tumor. It can happen. You can see that the right coronary artery, how it is encased with this soft tissue lesion. Yeah, the most common to be maybe metastasis, but the primary tumor, it could be what is called cardiac angiosarcoma. Yes. They mentioned that the cardiac angiosarcoma is the most common sarcoma in the heart. Yes. And they presented heart failure and cardiac tamponade. It happened in the right atrium and involved the pericardium. In the CT, low attenuation, right atrial mass, irregular nodular. Maybe the pericardial space obliterated with hemorrhage, as in this case. Anyway, as I show you, that it can have bit uptake. Don't know what happened, but okay, let's try to recording. Okay, thank you. Advance portion of screen. So I don't know how to show you this. Okay. So it have high uptake in the bit image. Yes, very high uptake. This is the source image, and you can see the high uptake in the cardiac images. Yes. So this is what is called angiosarcoma. Yes. So they mentioned that this patient is cardiac angiosarcoma. Perfect. Okay. Finally, maybe we can end this case with multiple lesions in the peritoneum. You can see that the peritoneum is already like infiltrated with soft tissue lesions. So how you describe this? When you describe it, you will mention that it could be it could be what is called peritoneal carcinomatosis, and you can see that there is multiple areas of increased FDG uptake through the supposed to be peritoneum. So you will search for the primary. If it is female, you will think that it could be like ovarian cancer or maybe breast cancer. But in this case, they find that the primary, in this case, that caused this peritoneal carcinomatosis was again colon cancer. So this case was primary colon cancer and sending metastases for the peritoneum. I wish that you enjoy today this session, and I hope that everyone is fine, and send me the feedback in the group. Thank you everyone. Assalamu alaikum.